Everyone. Thank you to the conference organizers for inviting me to present here. I hope you can all see me. I tried without this tool, but I don't think you'll be able to see me. So I will be talking about, I'll give a very, very high level summary of long-acting PrEP options for HIV prevention, and I will include pregnant and breastfeeding people. The perils of being on time. I think some of my slides will be outdated since we've just received a new global statistics. But as we heard from Anna this morning, we really have come a long way in controlling the HIV epidemic. Here you see that most countries, including Rwanda and Zimbabwe, we've achieved the 95 targets. So well done to all these countries in Africa for reaching the targets, the 95 targets. That having been said, there are still some pockets, some gaps remain. We know that the burden of HIV in women remains high with over 60% of people living with HIV being women. And we know that in 2023, we had 1.3 million people acquiring HIV, and 520,000 were women over 15 years. Back in 2016, we're very, very over-enthusiastic, optimistic that would reach, would get to less than 500,000 new infections per year. But come 2025, where are we? We are still having 630 new infections per annum. So the prevention gap is very high. Where we are at and where we should be, I don't know if I can use a pointer, but my slide here says we are here, which is 1,300,000 instead of 630 new infections. So even with U equals U and PrEP, there's still a wide prevention gap. So what we need is all hands on deck. The whole morning, there was talk about antiretroviral therapy, but here I'm going to be talking about all hands on deck for HIV prevention. So these are some of the HIV prevention options that we have. I will not talk a lot about oral Truvada. I'll talk about the vaginal ring. I'll talk about long-acting injectable CAB and lenacapavir. We'll also hear throughout the IAS 2025, and later on in this workshop, we'll hear about passive and active immunization as immunoprophylaxis. So what are some of the long-acting rings and films that we have for HIV prevention? The dapivirine vaginal ring, as some of you may remember or recall, this is a flexible silicone vaginal ring designed and manufactured by J&J, by Janssen, and it slowly releases the antiretroviral dapivirine over 1 month, and it's got a shelf life of up to 60 months, and it's very stable even at room temperature. So there's no cold chain needed for storage. It is woman-initiated, discreet, does not interfere with sex or menses, and this is the first ever long-acting HIV prevention product. So we conducted 2 phase 3 trials, which showed that the ring was well tolerated and reduced HIV infections by 30%. This was really modest early on in the phase 3 trials. But when we went on to conduct the open label extension studies, we saw that with increased adherence, there was greater risk reduction, increasing to up to about 70% from phase 3 studies. So the higher adherent the women were, the higher the protection. And then we went on to conduct additional studies in adolescent girls and young women, in pregnancy and breastfeeding. So those were the very first dapivirine ring studies, and they were the proof of concept studies that showed that, yes, a ring can prevent HIV. And then we now there's work on the dapivirine levonorgestrel. We are talking about mother-infant pairs here in this meeting, but I thought that I cannot not talk about contraception, because women here in sub-Saharan Africa, we suffer from a triple burden: HIV, STIs, and unintended pregnancies. So for a holistic HIV prevention model, we need to talk about STI prevention, we need to talk about unintended pregnancy prevention. So already work has started on a 3-month dapivirine ring, which delivers the active antiretroviral drug dapivirine at superior levels compared to the monthly ring. So as you can see, this is likely to cut costs because it will be a 3-monthly ring. This next generation multi-purpose ring was evaluated already in a phase 1 study, and the study was completed in 2024, and we await results soon. So this is a different ring, unlike the first one I spoke about, which is a silicone ring. This is the EVA ring, and it releases levonorgestrel and dapivirine. Also, there's a monthly alternative to the ring. In Matrix, before the stop work orders, we were working on a 30-day dapivirine film, which when inserted, women insert the film into the vagina. It can be used discreetly, and it can be inserted anytime and has no impact on sex. Low cost, no applicator required. Removal is not required. So this is one of the advantages of the film over the ring, because it gets totally absorbed and there's no need to remove, and there's no need to think about how to discard the ring, the used product after use. So it's got multiple advantages. So this is the monthly dual purpose vaginal ring with dapivirine. Once it had been shown that dapivirine, yes, does work in the form of a ring, work went on to look into the film, which was designed to protect from HIV and unintended pregnancy for 1 month. So this DPP, the vaginal film, will combine dapivirine and levonorgestrel. How will it work? Once inserted, it will release both levonorgestrel and dapivirine, preventing HIV acquisition and pregnancy. So what is the status of the dapivirine film? We completed this under Matrix 002. The prototype was found to be safe, acceptable, and all women could insert it successfully. What about another multi-purpose prevention technology? This is the One Ring, the Oak Crest non-ARV, non-hormonal multi-purpose prevention technology. It is intended to protect against HIV and pregnancy and potentially other STIs. It is designed to provide protection for 30 days, and it contains a non-ARV anti-HIV agent. So this is a natural occurring peptide for anti-HIV, and it contains a non-hormonal contraceptive agent, a salicylic acid, an adenylyl cyclase inhibitor as a non-hormonal contraceptive agent. So both agents are released independently, and they are supposed to prevent HIV, other STIs, and pregnancy. So what are some of the advantages of this ring? It's topical, non-antiretroviral, so it is anticipated to have fewer side effects, and return to fertility is anticipated to be very, very fast, within approximately a day after ring use discontinuation. What about long-acting injectables for HIV prevention? We all know about HP10083, HP10084, which showed that CAB-LA administered every 2 months does prevent HIV and is superior to oral Truvada. After that, work started on long-acting, ultra-long-acting CAB, and 2 strategies have been used for less frequent dosing. You could either increase the volume or the concentration of current CAB, which is currently 200 milligrams per ml, or develop an ultra-long-acting formulation with a long terminal half-life. So studies have tested increased volumes of CAB 2,000 equivalent to 800 milligrams, all the way to 3,200 milligrams with the use of human recombinant hyaluronidase, which increases bioavailability of the CAB. So unfortunately for these volumes, all injections had injection site reactions, which severely increased with increasing doses. So this strategy is no longer being pursued because of the unfavorable injection site reactions. So this is where we are at in terms of ultra-long-acting cabotegravir. And this will be looking at every 4 months. There's now a phase 1 single-arm repeat dose study. Participants will get 9 months of CAB-LA, and then they'll be switched to the ultra-long-acting every 4 months for up to 2 years. Lenacapavir, this is the new kid on the block. I will not go into the details, but what I want to talk about is that already there is work on the once yearly formulation of LEN, which is looking at 2 formulations, and both formulations are found to have, they maintain higher plasma concentrations compared to the twice yearly LEN, which we've been talking about. So there's a bridging study planned for PrEP indication for LEN. Oral, long-acting orals, there's MK8527. Already there's a phase 2 randomized double-blind study, which is looking at monthly oral MK8527, and phase 3 trials are planned in cisgender women and cis and transgender and non-binary populations in sub-Saharan Africa, and we'll be hearing about them shortly. I'll skip the tough silicone implant, which was found to have more side effects compared to placebo. I want to talk about pregnant and breastfeeding persons. We know that this will be talked about. Treatment coverage in pregnant women is around 80%, and it's not enough to stop vertical transmission. So we need to prevent HIV in pregnant and breastfeeding women. Thanks to Friday for this slide, we know that the cumulative HIV incidence in pregnant and breastfeeding people in sub-Saharan Africa is as high as 3.8 per 100 person years. And we know that countries where there's high fertility and long breastfeeding periods, there's also high HIV prevalence. And we'll hear from Nelly tomorrow that these same areas which have circled in red, they've also got high HPV rates. So all that is upon us African women. We spend about 7 years. Sorry, it's going on. We spend about 7 years of our lifetime. In Zimbabwe, women spend up to 7 years pregnant or breastfeeding, 9 years in South Africa, 9 years in Malawi, Uganda about 10 years. So we need to reduce the risk in pregnancy and breastfeeding. There are physiologic changes which make us women at risk for HIV. There are social issues which predispose women to HIV during pregnancy and breastfeeding. So we conducted an MTN-042, a phase 3B study, which showed that the dapivirine ring is safe when used in pregnancy and breastfeeding. I just want to call out to the team members of 042 who are here. This study included a stakeholders meeting. It really was a good example of good participatory practice. We included stakeholders meetings with key opinion leaders from each trial site, Uganda, Malawi, Zimbabwe, South Africa, researchers who gave us recommendations into the protocol development. We also showed in MTN HP10043 that the PrEP ring is safe during pregnancy and breastfeeding. And then in HP10084, we showed that CAB-LA is safe in pregnancy and breastfeeding. It was well tolerated in pregnant women, so these initial data provide reassurance regarding use of CAB in populations where pregnancy and HIV incidence are high, including Rwanda and Zimbabwe. And the potential benefits of long-acting injectable CAB in pregnancy and breastfeeding are humongous. We'll talk about this during the discussion. There's a reduction of HIV incidence by around 40% when CAB-LA is used in pregnancy. Famous Len, there were no deviations in pregnancy outcomes from population-level expectations when this study, when pregnant women were assessed for Len use during pregnancy. So in summary, childbearing individuals spend a lot of time pregnant and breastfeeding. We need to protect them. We need products that end users can use and are likely to use, products that can be manufactured and distributed locally at low cost, and we need products that will offer significant potential to curb HIV. And we need them to be accessible and affordable. At the moment, the prices of CAB-LA and lenacapavir are still quite restrictive, so we need them to be affordable and accessible. Thank you very much.